Perfect.
Perfect. So in the next few slides here, I'm going to be talking about percutaneous interventions in infective endocarditis. It is definitely an emerging field and a lot of excitement in a very, very difficult disease entity, very difficult population. The first thing I wanted to discuss is to mention the changes that we're seeing in the landscape of infective endocarditis, because that's definitely changing a lot and is mandating us to look for novel solutions to this population. First, the first change is really the demographic of patients with infective endocarditis has changed. In the past, it used to be young patients with just valvular heart disease or congenital heart disease, but now we're seeing patients who inject IV drugs, so a lot of tricuspid valve endocarditis because of that. We're seeing an aging population who are high risk for surgery. We're seeing more immunocompromised, the cancer patients, the immunosuppressed. We're seeing more indwelling catheters getting infected. We're seeing more prosthetic valves and devices, electronic devices, pacemakers getting infected, and patients with prior cardiac surgery, as I mentioned. Again, all of which increase the risk of surgery as being an option. And here are some numbers. In the US, there's about 400% increase in infective endocarditis due to IV drug use. And there's an increased admissions among younger patients, 15 to 34. And in JACC, the journal this week, we saw that although in this patient population, although surgery, we can get them through surgery, but there's a 32% rate of reuse of IV drug use, which is causing reinfection of their prosthesis. So it's a big problem in this country and in this patient population. So we're seeing also more TAVR infective endocarditis. We're seeing more pacemaker and device and ICD related infective endocarditis, with now about 10% of infective endocarditis admissions due to that. And these are the numbers showing the increase in IV drug use that we're seeing more and more recently, and it's just again becoming a very big burden. The other change that we're seeing in infective endocarditis is how we diagnose it. Here's some challenges in the current era. 10 to 20% of these patients have negative blood cultures on presentation in contemporary management of infective endocarditis. The prior diagnostic criteria, which is the classic Duke's criteria, had a lower sensitivity with prosthetic valves, infective endocarditis, as well as device-related infective endocarditis. And we're seeing recently more and more advances in the nuclear scans and the PET scans to help us increase the sensitivity and specificity of diagnosis of infective endocarditis. And in fact, because of that, all these there's the new 2023 Duke International Society criteria that have been now updated. This is a live document that's constantly being updated, and it includes all the new diagnostics, updated list of typical organisms, an updated predisposing conditions. And again, it highlights that the patient population is becoming higher risk and it's becoming more complex. Which brings me to the treatment. There are definitely changes in the treatments of infective endocarditis, and antimicrobials, antibiotics continue to be the spine of the treatment of infective endocarditis, but there's some changes to possibly the duration and the type of antimicrobials based on recent trials, the POET trial. Surgery, again, it's also a cornerstone in the management of infective endocarditis, but unfortunately, the reality is because these patients are becoming more complex, 24% of them do not undergo indicated surgery, and that's because of liver disease or they have stroke, and so there's a risk of hemorrhagic conversion in the operating room, and then the risk of reseeding, like I mentioned, in the IV drug use population, they inject IV drugs, they undergo tricuspid valve surgery, and then they get discharged, they go back to injecting drugs again, and they reinfect their prosthesis, and it becomes a big, big problem. Another change in surgery that we're seeing is early surgery. Why wait? This is like everything in valvular heart disease is shifting towards early management rather than just waiting for problems to happen. Because quite honestly, the classical indications to operate, which are heart failure, continued sepsis, and continued embolism, are based on old observational data that are outdated. And so, again, there's a shift to doing things early on and that repair is possibility in surgery. And then, as I discussed earlier, the surgeons are also feeling the increased complexity in patients in infective endocarditis, hence the risk of surgeries going up. So for example, explanting these TAVR valves that are infected are associated with high morbidity and mortality. However, recently, and that's a new treatment modality, because of the increased complexity of patients that I just mentioned, there has been an advancement in the technologies to treat and aspirate pulmonary embolism, right? These catheters that we go into the pulmonary arteries and aspirate this clot. Well, because of the burden of, and it's all started with the IV drug use population, because of the burden of this disease and its implications, well, we started applying these same catheters that aspirate clot in order to aspirate vegetations. And this is how it looks like. We have several catheters. We just basically park them close to the vegetation and then aspirate them. And I'll go into the little bit of the details. This is an example of what we do. We just try to aspirate the vegetation as much as we can. The purpose of this is the following. As you all know, the pathophysiology of endocarditis starts with the endothelial injury on the valves, the organism seeding on the valve, and then it creates this clot around it full of thrombin, sometimes a biofilm if there's a device, and that helps it avoid the immune system. But when we aspirated the vegetation, and we're hoping we disrupt the vegetation and increased antibiotic efficiency and lower the embolic risk, hence achieving better source control. So that's the whole goal of doing these percutaneous mechanical aspiration procedures. And so how do we select which patients qualify for that? We base it on three things: the vegetation characteristics, the patient-related factors, and then the device characteristics. Let me go into a little bit of details regarding that. Vegetation characteristics. The first thing we look at is the location. Is it in a location where we can feasibly retrieve it with our current catheters? Most typically, the best locations are on the right side of the heart, typically the right atrium, the atrial side of the tricuspid valve, the mid-RV, and then the pulmonary artery, and just beneath the pulmonary valve. Anything beneath the tricuspid valve is very difficult. Anything at the apex of the heart, of the RV, is a little challenging because it's a small space, and aspirating in a small space can be very challenging. It can cause arrhythmias, and so those are challenging. I wouldn't say not doable, but they're definitely more challenging. Anything in the left atrium and on the mitral valve is doable. On the aortic valve, now we're doing more and more of that because there's been advancement in the technologies. But anything in the left ventricle is challenging. Anything underneath the mitral valve is near impossible. But again, I wouldn't say that I would rule it out fully, but it's just more challenging. The other thing we look at is the vegetation characteristics. We like the large, mobile, and acute vegetations because those are the softest ones and they can easily come off, as opposed to the diffuse, sessile, and chronic vegetations. These are pretty stuck on the valve and they pretty much don't come off easily, and the chances of success is low. The pathogens, bacterial infections are typically the culprit in these, and the most experience has been with those. The fungal ones are a little bit worrisome because obviously if we disrupt a fungal vegetation and cause a systemic fungemia, the patient can get into trouble easily. But that being said, fungal infections have been aspirated. They tend to recur more, and the systemic fungemia risk is definitely worrisome. But we need more data to support that. We then look at the patient-related factors as well. So we look at the pulmonary reserve. So many patients come in with septic pulmonary emboli, and so their risk of having another embolic event is less tolerated. So it makes us want to use stronger aspiration devices because we don't want that vegetation to end up in the lungs and cause another hit. So that has implications on patient selection for our procedure and device selection for our procedure. Same thing, even if it's a right-sided infective endocarditis, we look at PFOs in all these patients before aspirating them because during the procedure we can disrupt the vegetation, and part of it can cross the PFO and cause a stroke. And so here's a patient where we put in a sentinel device. It's an cerebral embolic protection. It's basically baskets in the arch of the vessel, the arch of the aorta vessels that catches the embolic material if it embolizes, and that's a tricuspid valve case. And you can see here that because the patient had a PFO, some of that material did cross and get caught. Luckily, the patient did not have a stroke because of that, but that's just something to keep in mind. Finally, we look at the device characteristics. Again, these devices come in different shapes, sizes, lengths, and maneuverability. So it just depends on the location, shape of the vegetation, the anatomy, as well as the characteristics of the device. We factor all these things in and basically select the right patient and the right device for that patient. The devices are divided into two main categories. They're divided into large bore aspiration and small bore aspiration. The large bore ones generate very high aspiration forces, and so we don't need to contact the vegetation. We just put the device close to it and ramp up the aspiration forces, and we can aspirate it. Whereas small bore ones are smaller, they require us to contact the vegetation, thus the risk of distal embolization because of that. But they're smaller, they're more efficient. This is the device we use most commonly. It's called the AngioVac device. It's made of an outer cannula and an inner cannula, and the inner cannula has different shapes that we just push it out of the outer cannula, and it forms these different shapes, depending again on the location of the vegetation and how we want to shape that catheter. The way it works is we connect one end of the AngioVac cannula, which is the aspiration catheter. We connect it to a perfusion or an ECMO circuit that we get those from the operating room, from the cardiac surgical operating room. And so we get a perfusionist and an ECMO cannula. We connect it so it just pulls the blood, puts it through a filter that connects the specimen, and then we return the blood through another separate access. So it is a veno-venous ECMO circuit established for this aspiration. We can ramp up the speeds of aspiration basically by just ramping it up on the machine here, and it changes the speed of aspiration. Again, here's the same animation here. This is the AngioVac cannula. This is the outer cannula, the inner cannula, and that's the vegetation. We place it as close as possible as we can, and then ramp up the speeds, and it just aspirates the vegetation. Here are other devices that are less commonly used but available, that do not require a setup with ECMO, because I know it's a logistical challenge sometimes to get ECMO set up. This is called the AlphaVac. It's the cousin of AngioVac. It has a plunger that we connect. It's the same device, but instead of connecting to an ECMO, it has a plunger. I'm not a fan of it because I like continuous aspiration for these, right? It's an infected material. We don't want it to embolize distally. I like continuous suction, and that's why I like AngioVac the most. But this is an alternative. Again, this requires contact with the vegetation, so there's a risk of distal embolization. Here's another one. It's called the Inari Flow Retriever. The way it works, it's a tube that's connected to a syringe. So we pull negative suction on the syringe close to the vegetation. It aspirates it. Again, it's not continuous suction. Here's the smallest catheter that we have that we can use in these cases, and it's called the Penumbra. And basically, it's a tube connected to an engine that just pulls blood intermittently. Again, not continuous suction. Small. It's modest aspiration forces, and we can't return the blood here, so there's blood loss associated with this procedure. And this is how we use it. Small bore, so we have to contact these vegetations. The vegetation has to be small enough, but if it's large, then this is not effective to remove it. So in summary, just the large bore aspiration, large aspiration forces, we don't need to contact the vegetation, and minimal blood loss, because in AngioVac, for example, we can return the blood. But it is larger catheters, so there's a larger risk of bleeding, and it's a logistical challenge with the ECMO. Whereas smaller ones, it's a quicker setup, single access, minimal injury to the valve, but less effective aspiration forces, more risk of distal embolization, and in some catheters, there's some blood loss associated with that. So now with this information, let's talk about the applications of this technology to highlight some of the things we've been doing with this in endocarditis. Let's start with a case of a 28-year-old, history of IV drug use, presented with fever and chills. You can see here a large tricuspid valve vegetation. in two views. And almost always the culprit is Staph aureus in these patients. Now, they can have multi-organism endocarditis because what these patients end up doing with IV drugs is they lick the needle and inject it through a vein, so they can have multiple bugs growing in their blood. But Staph aureus is the most common one. So this patient continued to have Staph aureus sepsis despite antibiotics. So we decided, and the surgeons, like I said earlier, the surgeons are not excited by these patients because they what ends up happening is they take them to the OR, do tricuspid valve surgery, and then they unfortunately, most of them relapse into drug use and they reinfect their prosthesis. So that's why we decided, well, let's do source control because of the ongoing sepsis. Let's do source control with percutaneous mechanical aspiration. So in a step-by-step approach, we put the outer cannula. We then extrude the inner cannula. We turn on slow suction and approach the vegetation with slow suction on. Again, we want continuous aspiration ongoing as we approach the vegetation. When we're close to it, we ramp up the speeds of aspiration and the aspiration forces, and we pull the vegetation through. We aim for about more than 70% debulking of the vegetation. So we like to remove 70% of the vegetation, and we obviously don't like complications. So this is that we used intracardiac echocardiography for this one. You can see the vegetation here, and then the angiovac cannula, you can see it right here. You can see it going in and out of the intracardiac echocardiogram, but here's the cannula. And lo and behold, we retrieve the specimen, and the nice thing is we send it out to pathology, because sometimes we can see one bug in the bloodstream and we miss the multi-organisms that we can actually culture from that specimen. So it's nice to have the specimen in these patients. And note what happened to this patient. This was blood cultures this positive despite antibiotics, and when we removed the vegetation, the blood cultures cleared. We achieved source control. And one of the earliest things we're seeing in these patients is actually an abrupt drop in the white blood count which is again a sign of source control and successful source control in these patients. So this case really highlights IV drug use, persistent sepsis despite antibiotics as an application of this intervention. Here's another example of a 32-year-old female with a history of IV drug use again, fever, chills. She left against medical advice, and unfortunately, a week later, she felt much worse, came back to the hospital. And again, just a large tricuspid valve vegetation. You can see here that at the base of the leaflet, you can see some color going through, and that suggests that there's now a perforation of the base of the leaflet of the tricuspid valve. Again, she grew Staph aureus, the most common bug. So again, we decided to go ahead and achieve source control with percutaneous mechanical aspiration with angiovac. And we created an imaging sequence so that we are in synchrony with the person imaging our procedure and us who are doing the intervention. This is the thing now with structural interventions, that there's a common language between the imager. So for all of you who image, this is the sequence that we use for these procedures. The first set of images we get is to assemble the cannulas. The second set of images show us advancing the cannulas towards the vegetation and aligning it with the vegetation, and then ramping up the speed to aspirate it. And this is the angiovac cannula aligned with the vegetation right here, and we successfully aspirated the vegetation. But notice what happened here. There's now, you can see the color even more, and it looks worse. The tricuspid valve regurgitation looks worse, and the reason is we uncovered the perforation, right? The vegetation was covering the perforation. All we did was uncover it, and that's the mechanism of the worsening of the tricuspid valve regurgitation in these interventions, is because we uncover the vegetation. And sometimes because of the leaflet is unhealthy, obviously because of the infection, sometimes the cords break, rarely, and that's the other mechanism of worsening tricuspid regurgitation. However, this is still a win in these patients, because worsening tricuspid valve regurgitation is tolerated, right? And it allows us to send the patient for a couple of weeks to rehab in order to treat the real underlying problem, which is the addiction, and then send them to surgery after that. So that lowers the risk of having them reinfect their prosthetic valve. So it's still a successful strategy that we adopt. So that's the third application, which is these procedures are intended to be a bridge to surgery in many situations. Let's talk about another example. A 44-year-old hypertension, hyperlipidemia, non-ischemic cardiomyopathy. He had a defibrillator placed. However, 3 months after placement of the defibrillator, he had fevers, chills, hypoxemic respiratory failure, transferred to us with staph aureus septicemia, multiple septic emboli to the lungs. You can see here the cavitations. Septic emboli is a horrible thing to have, and they remained ongoing despite antibiotics. So ongoing sepsis and ongoing embolism despite antibiotics. And the TEE showed a large vegetation on the defibrillator lead, so on the ICD lead. So historically, if this was not done in the OR and he's not a surgical candidate, if he just pulled the lead out, this thing is going to dislodge into the lungs that already have multiple septic emboli. It's not going to be tolerated. The patient will pretty much code on the table. So that's why another application, another strategy is to aspirate this vegetation off of the lead in order to facilitate safe retreat or safe extraction of the ICD lead. So the way we do this is we basically connect or extrude the cannulas in the right atrium, turn the speed, the suction speeds on, cross the tricuspid valve into the right ventricle, align with the vegetation, and ramp up the speeds. So here's the angiovac cannula, and here's the vegetation. Here's how we align them. We then explain across the vegetation to see it in 2 views, and we use fluoroscopy to guide the cannulas to the lead, and then we ramp up the speeds and aspirate the vegetation, and here you can see it aspirated. Now, during the process of aspiration, sometimes the cannulas tug against the wall of the right atrium because it was a smaller right atrium, right ventricle, and it could cause some ventricular arrhythmias. So we have to kind of reposition so this is an example of it right here. So we have to just slow down the speed, readjust the cannula, and then reorient it towards the vegetation. So so again, we retrieved the vegetation, and that allowed safe extraction of the lead without us dislodging that vegetation into the lungs. So the patient did well with that, and this highlights the other 2 indications, which is recurrent embolism despite antimicrobials, and then in order to facilitate device extraction and source control in device-related infections and infective endocarditis. So that's another utility of this technology. So the last application of these technologies, we all face this problem, right? We get called about someone with fever. They have this thing wiggling on their leads or on their valves, and we're not sure, is this a clot? Is this a vegetation? The nice thing about this technology, it allows us to now sample these vegetations and send them to pathology to take a look. And here's an example of, this is the wiggly echo density. Patient had fever, but again, we're not sure, is this a clot or vegetation? So we went in with the penumbra. It's a small bore aspiration catheter, 10-minute procedure, really, 10-15 minutes. We just turn it on, it aspirates it, we retrieve it, send it to pathology, and this was a clot. So we didn't have to remove the device, which is nice. It's a big decision. Here's another example. This is a patient who had a PFO closure device, but 3 days later presented with, some leukocytosis, some low-grade fever, and chest pain. So you can see here that there's this echo density on the right atrial disc. You can see it in another view here. It's mobile. Again, we were not sure. Is this just 3 days post-procedure? Is this an infection? We did all the multimodality imaging, cultured her, everything was negative, but we're still not sure, because if this was infected, it has to come out surgically. And if it's not infected, then we'll just leave it in and treat it with the appropriate therapy. So we sampled this, same thing with intracardiac echocardiography and the small bore aspiration device, and sent it to pathology, and it was all thrombus. So we just gave her anticoagulation, and she did really well with that, and follow-up clearance of the echo density. And she did well with that. So that's the last application of this procedure, which is in diagnostic ambiguity. And so when we're not sure about the diagnosis, we can actually sample the tissue and send it to pathology. So is there data to support this practice? There is, and there's more in the pipeline, but there's a couple of registries. The RAPID registry showing a high success with an acceptable risk. Only it's just a subset of these patients had endocarditis. There's a STARK registry of 100 patients undergoing, they had all lead-related endocarditis. So it showed that actually when you aspirate, it leads to successful and safe lead extraction without pulmonary embolization. There's a couple of case series showing the feasibility. Some of them raised some concern about worsening tricuspid regurgitation. Some raised the concern about worsening mortality in patients who present with septic shock. So it may be futile actually to do these procedures in patients with septic shock, because again, they already are at high risk for mortality. And then there's the most recent series showing that it's feasible, safe, and there's 100% culture clearance with these procedures. We've shown that the rate of aspiration in the US here has been increasing, and surgery has been steady, because again, sometimes this is a bridge to surgery, but it's definitely, there's an increased use of it. It's been mentioned in several scientific statements. So here's a scientific statement of HA1 of management of infective endocarditis in IV drug use. So aspiration is now a proposed method for treatment for these patients. Same thing for the European electrophysiology guidelines. They proposed that as a device that can be used in patients with infected leads as a bridge to safe extraction. And most recently, the 2023 ESC guidelines for management of infective endocarditis gave it a class 2B recommendation to use it in right-sided infective endocarditis. Later this year, you're going to be hearing more about the results of the multi-center registry that I'm the principal investigator of. So a lot of exciting data coming this fall about that. There's also an upcoming trial. Doing a clinical trial in these patients is very challenging. One, they're sick. Two, especially the IV drug use patients, they tend to have a large loss to follow-up. So the best clinical trial design for these is in patients who have infected devices, ICD leads or pacemakers, and the trial design is aspiration and extraction versus no aspiration and extraction. And they all come back for follow-up because they have to do the device check. So that's the best design for a clinical trial, but that's upcoming as well. It hasn't started yet, but it will be starting very soon. What about left-sided endocarditis? So obviously it makes us all nervous, right? It's the left side, there's a stroke risk that's, and as well as obviously coronary occlusion risk, mesenteric ischemia. It's a scarier zone to aspirate in. So I started going to the operating room, scrubbing with the surgeons to see to feel these vegetations and see, if they have consistency. Is it going to splash all over if I put the device in? Turns out that these vegetations have a lot of consistency in them, and they obviously have to have enough consistency to tolerate the opening and closing of the valve. So we started applying these aspiration devices on the left side as well. So here's an 82-year-old. She had recurrent strokes, and despite antibiotics, she had group B strep with a vegetation on the mitral valve, as you can see here. So we decided to do source control with the aspiration via transeptal route. So we do a transeptal puncture, turn on the suction, and approach the vegetation while suction is on. You can see here we start all our procedure with cerebral embolic protection. So we put these devices in order to protect the arch vessels. We then do a transeptal puncture with a wire called a safe sept. It just goes straight into the left upper pulmonary vein, and it creates a rail so that we don't have equipment falling in and interacting with the vegetation as we pass on the devices and the catheters back and forth. And here we just extrude the aspiration device. We turn it towards the vegetation. And then you'll see here that here's the device, here's the vegetation. We approach it while the suction is on. And you're going to see it here getting pulled into the catheter. I'll play that one more time because it shows it very nicely. Sorry. There we go. Just focus your attention here. You see how it just pulls it in, and 70% of it, more than 70%, we were able to clear most of it out, send it to pathology. Definitely grew B strep. No stroke. We interrupted the recurrent strokes, which is nice, and the patient did well with antibiotics. And that. Here's another example: prior surgical ring. This is our catheter oriented towards the vegetation on the ring, and in 10 minutes we were able to get this out. Patient tolerated it, no stroke. She did really well with that. Here's another example of a 57-year-old male with lung cancer presented with recurrent strokes. You can see here that he had these vegetations on the tip of the leaflets and what we call a cotton bud appearance. This is typical of non-bacterial thrombotic endocarditis, which is basically clot developing on the valves because of a hypercoagulable state such as cancer. And we see that also in lupus, right? We've all seen that. So, but this patient continued to have strokes despite anticoagulation. So we actually went in. Here's the aspiration catheter, and we were able to aspirate the vegetation. So you can see here that we locked the device and engaged the vegetation, and it came out very nicely. It's again the consistency that I was telling you about. It came out as one piece, so we were able to interrupt these recurrent strokes. We've also done these in bioprosthetic valves. You can see here, this patient had now mitral stenosis. This is a third redo, so she would not have tolerated a fourth sternotomy. She was a little older, so you can see here large vegetation. So we decided to do source control, and here's the angiovac cannula. And look at that. I mean, it pretty much cleaned up the valve very well. We keep those on chronic suppressive antibiotics forever because it's a prosthetic valve. And you can see here that the gradient across the mitral valve went down from about 12.5 to about 6.5 after the aspiration. So it made a significant impact, and the patient is still doing well with that. Here's the most recent case I've done. This is actually a patient who had a freestyle. It's a bioprosthetic valve, who's had presented with endocarditis and this vegetation. She was treated for it for a full course of antibiotics, but then she completed the course, cleared her culture. So now this is a sterile vegetation. So it means that it's what's remnant of that infected endocarditis. It's not infected, it's a sterile vegetation. But unfortunately, the bioprosthetic valve fell apart, and she had aortic regurgitation that was severe. So we wanted to do a TAVR on her. So we want to put a transcatheter aortic valve inside her failed bioprosthetic valve. But she had that sterile vegetation still on, and we were worried that we were going to dislodge it with the TAVR valve and cause a significant embolic risk. So we decided to aspirate it in order to facilitate safe TAVR. So here we put this angiovac cannula right here, and close to the vegetation. You can see it here that we engaged the sterile vegetation, and we were able to pull it out successfully. It was all pretty much this was not infected. The culture was negative. It was just healed thrombus. And you can see here that's another view of the angiovac in the aortic position, and then the TAVR afterwards. And the patient did great with that. Now, we've also applied it in, again, ambiguous left-sided cases. So here's an example where a patient presented with stroke, was unclear what this was. We didn't know if this was a vegetation. Cultures were negative. So we went ahead and aspirated it. And lo and behold, we uncovered actually a papillary fibroelastoma. This was not a vegetation. So subsequently, the patient went to the operating room a few weeks after the stroke. We don't like to send them immediately after, and underwent resection of that and showed the papillary fibroelastoma. Here's another example of, again, someone who presented with sepsis. He's high risk for surgery and had this mobile echo density on the inner atrial septum. So we decided, here's the angiovac cannula, and here's the mass. That was unclear. So we put this was difficult to aspirate alone, so we had to put a snare around it while the suction is ongoing. And then you can see here that we ramped up the speeds while tightening the snares. And boom, came out. And it ended up being a myxoma. It was not it's not infective endocarditis. So again, these help with the diagnosis. There's another example with that was a patient sepsis, unclear what this was. We aspirated it, sent it to pathology, and it was calcific amorphous tumor. It was not an infective vegetation. Now, we've been pushing the envelope as well on many other frontiers. So this is a patient with a peri-aortic abscess. You can see here it lit up, prior TAVR, high surgical risk. So we went up actually with our catheters into the peri-aortic abscess and aspirated it. And again, we were able to clear the infection. You can see here that that's before the aspiration, and that's after aspiration. We were able to clear by just draining the abscess. We were able to clear that the infection. So so that's again another exciting frontier on percutaneous infective endocarditis. The last thing I wanted to touch upon is because of this. Because of these changes and because of the additional therapies like the aspiration ones that I just showed, we have now dedicated endocarditis teams. So we have every endocarditis case that presents to the hospital, we log on to a Zoom. We have an endocarditis team of cardiac surgeons, interventional cardiologists, imaging specialists, infectious diseases, neurologists join. We talk about the case. Addiction medicine is very important. Nutrition is very important. And this approach has changed the way and the outcomes that we have with these very challenging population. And I'll give two examples to highlight it. Here's one example of a patient, 48-year-old, IV drug use. She was referred, she was seen by a cardiologist because of an infected tricuspid valve, sent to a cardiac surgeon immediately without undergoing the robust endocarditis team approach. So she was sent directly to the cardiac surgeon. The cardiac surgeon, of course, operated on the valve. Then they discharged the patient. The patient, not surprisingly, underwent. She relapsed into drug use, infected her biprosthesis, and unfortunately, she was sent back directly to the surgeon. And the surgeon was left with no option but to just remove her tricuspid valve. So this patient has no tricuspid valve. Look at that. Wide open. This is the for those who are in internal medicine, this is the right ventricle, that's the right atrium, and there's no tricuspid valve. Now, how is a 48-year-old patient going to do without a tricuspid valve? Not so well. So this is because there was a breakdown in the care of this patient, where it was just sent directly to the cardiac surgeon without undergoing the holistic approach. And as opposed to this patient who I showed earlier, presented with sepsis, endocarditis, and they had a perforation, right? We needed to send them to surgery, but we were worried about the relapse of infecting the prosthesis. So that's where the endocarditis teams have, and there's a publication by Dr. Yusel on it, on this model of care of multidisciplinary approach, a holistic approach to endocarditis, in order to optimize and lower the risk of reinfecting their prostheses. And so this, as I showed earlier, we aspirated, we sent the patient to rehab for a few weeks, and then the patient was sent for tricuspid valve replacement and did not relapse into addiction and did not reinfect his valve. So that's the power of having an endocarditis team. With that, I would like to thank you all for your attention. And please feel free to ask any questions, and I'm looking forward to the discussion.